Hello, it's Natalie Benet again. Today I'm going to walk through some slides of ovarian epithelial neoplasms. As I'm looking at them on a virtual slide, this is going to be mostly ad lib, just simulating the experience of sitting at a microscope with a pathologist just to see how we approach slides. We can pretend we're at a double-headed or multi-headed scope together, and you can get an idea where I go to look at what's important, etc. So we'll start off, and it'll follow the same basic outline of the video recording I made, which is a more traditional presentation. So we'll start with serous, then move to mucinous, then endometrioid, then clear cell, then Brenner, and then finish up with serum mucinous neoplasms. And I will zoom in and out as I go. So this is the first slide, which is of an ovarian mass, and I know the final diagnosis is a serous adenofibroma. And these here, I can see this is the surface here, which someone has put ink on, which is a pretty standard thing to do on the ovarian surface. These are blood vessels, and I can tell that this is normal ovary right here. These are corpora albicans, so this person has ovulated at some point in their life. And then we move on here, and I can tell that this is the lesion of interest. This would have been a cyst, with the area at the top of the screen being the contents of the cyst or the inside of the cyst. And you can see here that it's lined by these club-shaped papillary formations. And when you zoom down, first we'll look at the cell of origin, which is usually the first thing I do. And you can see that there are cilia present. So this is a serous neoplasm. And these club-shaped projections don't really fit the model of a borderline tumor. They look more like a serous adenofibroma. The final diagnosis for this does say that it had focal proliferation, which means someplace else in the case it likely had areas that more closely resembled a borderline tumor. But we're starting out at the simplest end of the proliferation. So now we'll move on to the next slide. And this is a serous borderline tumor with some more interesting things going on in it. So this is kind of a complicated case, but we'll start off with the part that's a little bit more simple. So if you zoom in here as compared to that last case where we had the club-shaped projections, these do have what we call hierarchical branching, which means they start off branching kind of wide and then they branch a little bit more narrow. So this is a good example of borderline architecture here. These are a bit edematous. I'll see if I can go to an area here. This right here is a really good example that I'm moving over with my mouse of borderline architecture in an ovarian neoplasm, especially serous and serum mucinous neoplasm. So this is what you would want to be looking for. Some other characteristic features are these eosinophilic cells, which are detached here up at the top. When you find areas of microinvasion, those will be diving down into the stroma. So that's kind of what you want to look for, not microinvasive disease, but microinvasion, the one that we talked about that doesn't really affect prognosis as far as we know. So that's there. And then the other interesting thing about this slide, and this patient ended up having a more interesting diagnosis elsewhere in her ovary, I imagine that she had some micropapillary architecture because she does have invasive disease here. So she has diving down into her stroma these papillary projections, which are lined by cells that are morphologically a little bit different. They resemble sort of a low-grade serous proliferation. So these are invasive implants arising within a borderline tumor. So whenever you see something like this, it doesn't really make sense. It's not really matching up. You always want to go back to the bucket and really extensively sample because these are invasive implants here in her ovary. So that's a bit of an unusual case, but it does have some good teaching points in there. So then I wanted to show you a good example of a micropapillary serous neoplasm. So we'll start at low power here. This is multiple fragments. It was probably cystic. And like we talked about, when you're either at frozen section or grossing that specimen, when you crack it open, you want to look for those little hard white areas that look almost like cauliflower. And that's what these would have been. But the other thing that's interesting is that this one here on the left upper hand corner is mostly intracystic. So if you weren't carefully sectioning to find these and just sort of pat along the top and making big sections, you might miss these. They might be hiding inside of a cyst. So always keep in mind that ovaries can be tricky. Assume that you have to really get in there and look hard. Most of the other cyst fragments are actually pretty simple. So it looks like this might have actually arisen in something that looks more histologically like that first case of a serous cystadenoma. So very simple lining, but obviously we have things here that are more complicated, which is what we're going to focus on. So these are micropapillary projections. What does that mean? Well, that other borderline case we looked at, the borderline serous tumor, had that hierarchical branching. So it had sort of an intermediate step that led to these little projections, whereas this one just has the head of medusa or caput medusae. It goes straight from being a big club to being very narrow, right? So those micropapillary projections. So this is a micropapillary serous carcinoma. And these are the cases that you're going to want to extensively sample. They're more commonly associated with advanced stage, and you're going to want to look very carefully for those invasive implants or more serious things going on. And I'm trying to see if there's anything else going on in her ovary, which would be interesting to look at. Not so much. Okay, so we'll go to the next slide now. This is an example of, this is fibroadipose tissue. Frequently we get these, this looks like it might actually be associated with this patient's ovary at all. This was a publicly available slide on Path Presenter, which I thought was interesting because it's sort of, these might have been biopsies taken at staging, which happens a lot for gynecologic cancers. Surgeons will go in and look around the abdomen, take out everything they can see to reach something they call optimal debulking, which is very important for patients. The idea being that if you don't leave behind big pieces of tumor, whatever you might happen to leave behind, the microscopic foci that you can't see with your eye, can be taken care of with cytotoxic chemotherapy, which is given after surgery. So this is an example of high-grade serous carcinoma, so not the low-grade that we were just looking at. Those invasive foci had that morphology. This is high-grade serous carcinoma, and how do we know it's high-grade? Well, you go down to high power, you can see there's a lot of mitotic activity. There's also pleomorphism, so meaning that the cells look different from one another. You have atypical mitoses, not just mitotic activity. Macronucleoli, so nucleoli you can see at a relatively low power. And yeah, the nested architecture, and you can clearly see that this is some sort of fibrous fibroadipose tissue, and it's clearly infiltrative. And then I think we have one more example here of serous carcinoma, which is high grade. It's high grade ovarian serous carcinoma, and this looks like it's in the ovary, right? And so you actually have necrosis here, which you can or can't see. It doesn't need to be seen in high grade ovarian serous carcinoma. Whenever you see necrosis, you always just want to think, am I looking at a high grade tumor? You not necessarily are. This has a lot of other good features like apoptotic cells, so cells that are just dying. Those similar features to the case we just saw with the macronucleoli and the pleomorphism. And I'm trying to see mitotic activity. So this is a good contrast to those low-grade serous carcinoma cases where you won't see those morphologic features necessarily. Okay, now we're going to move on to mucinous tumors. So this is a mucinous cystadenophibroma. And once again, just like the serous case, you start off at low power. You always want to look and see, what am I dealing with? Is this actual ovary? Is this probably a mass? So this was probably a cystic mass, right? And this stuff out here was likely the surface of the ovary, with this stuff being the inner surface. That's why it always helps to stick a little bit of ink on that tumor at frozen section or when you're grossing it. So when you're under the slide, sometimes these cyst fragments can get twisted around and shoved together, and you want to see what you're dealing with. So in contrast to the serous cases, which had cilia, these have those nice intracytoplasmic mucin and no proliferation here, so no stratification. The cells are not stacking up on top of one another. There's nothing complicated going on, no borderline architecture. So this is a nice example of a mucinous cystadenoma, or I suppose if you wanted to call it a mucinous cystadenophibroma, because there's a little bit of fibromatous proliferation, nobody would argue with you. Those are both benign diagnoses and sort of exist on a continuum. There is a little bit of something here that might get confusing for those starting out. So you see here, this is a simple layer here, and you have a little bit of, it almost reminds you of a colon biopsy or something, right? And these are probably actually just tangential sectioning of the tubules, which gave rise to this surface proliferation here. So just to have a borderline tumor, you really want to see more outpouchings and projections. So that's all okay. That's still covered within a mucinous cystadenoma. And now we'll move on to a mucinous borderline tumor. You see here lots of stroma at low power. You see this is probably the outer surface of the ovary here, and some edema of that ovarian tissue between the outer surface and where we start to see neoplastic proliferation, but clearly more proliferation than we saw in that cyst adenoma that we just looked at. So you have these tufts here and still some tangential sectioning, but a lot of proliferation going on at the surface, right? These papillary projections. And when you're looking at mucinous borderline tumors, what do you want to look for? You want to ask yourself, okay, I've decided this is a borderline tumor. Now, is it carcinoma? How do I get to carcinoma? Well, there's a couple different ways to get there, like we talked about in the video. Intraepithelial carcinoma, which carries a different prognostic implication for mucinous carcinoma, sort of de facto. So what do you want to look for mucinous carcinoma that's not intraepithelial? Confluent glandular architecture. Kind of like you think of for an endometrioid proliferation. Are the glands touching? Is there an invasive pattern, like clear invasive fossa diving into the stroma? And I know this is a difficult distinction because the architecture of a borderline serous tumor has those nice club-shaped papillae, but for mucinous borderline tumors, what you're really thinking of is more of almost like a gland-to-stroma ratio. So this is still okay within the spectrum of borderline mucinous tumors with those surface projections. And when you're actually sending these cases out, because they can be very large, you want to make sure you've submitted enough tumor. And then you really need to get comfy and zoom in on high power and make sure you're not finding those interepithelial foci. Make sure you've sampled it well. And for right now, that should suffice for the mucinous borderline tumors. But we'll move on to a mucinous carcinoma. So this is an ovarian neoplasm. You can see at low power, a lot more complicated than that case we just looked at. Over here on the left, this actually just looks like it's completely dead. Necrotic tissue, which, like I said, doesn't necessarily mean anything because ovaries of all shapes, sizes, and malignant potentials can torse themselves. But you can see here you have some glands sort of leading into that necrotic material. Not usually a good sign because this is looking like a carcinoma. And you can see the destructive sort of invasive pattern. And then also when you go to higher power, there's a lot of nuclear atypia here. You can see compared to that case we just looked at, the nuclear atypia here is approaching that level we saw in the serous carcinoma. So this is a good example of a mucinous ovarian carcinoma. And now we'll move on to endometrioid proliferations. This is an endometrioid adenofibroma. I can't tell that from here. I know that because this is a case which is from my study set, but you can see at low power when you're approaching an ovarian neoplasm that this was probably the outside of the ovary and this was taken. And this doesn't look like it has ovarian surface in it, but you can see a lot of stroma, a lot of pink stromal cells in this case. And once you zoom in, you can see that the glands are pretty widely spaced, not really touching one another. You go down into higher power, and these are nice endometrioid type glands. So they do have some mucinous morphology, but not that nice intracytoplasmic mucin of a mucinous ovarian neoplasm. So this is a good example of an endometrioid adenofibroma. Now, once you get into endometrioid adenofibroma, it can get a little bit tricky. You can start wondering like, okay, is there hyperplasia here? Am I getting into endometrioid carcinoma? And I can just say for right now that the spacing of these glands looks okay for endometrioid adenofibroma. I don't see anything here that makes me want to call this a carcinoma. Those are kind of more sophisticated conversations, but for right now, the adenofibroma has both fibrous stroma and glands, so adeno and fibroma. And then we'll move on to a clear-cut case of endometrioid adenocarcinoma of the ovary. And this is good because it also has some of that fibrous stroma, but you start to see these glands are getting a lot more complicated, branching. It always helps for endometrioid adenocarcinoma to see some nice squamous morgular metaplasia, but you don't always get that gift from the tumor to tell you the tumor type. But you can see here, this glandular complexity, there's cribiforming and then apoptosis, mitotic activity, and more nuclear pleomorphism than that case we just saw. So this is a good example of an endometrioid adenocarcinoma arising in the ovary. Always helpful to find that squamous morgular metaplasia, which I don't see in this case. The other thing that's usually or can be helpful is to see endometriosis, because we know in some cases at least that that is a precursor lesion for these lesions and makes you feel better about the diagnosis. Now you see we are getting some of those metaplastic changes that you can notice in the endometrium, but I don't see any squamous morgular metaplasia. I just always like to find that because it makes me feel better. Now we'll move on to a case of clear cell carcinoma. So at low power, once again, I see over here at the outside, actually that looks like fibroadipose tissue. So it's possible that this patient had a an ovarian adhesion to the side wall, and it was sort of peeled off. A good time for me to mention that no matter what your level of training, reading the operative note is always so important for these cases. You can find out what the surgeon saw, whether or not they think other organs were involved. That doesn't always mean that you'll confirm that on the slide, but at least you know maybe this ovary was stuck to the other ovary and they peeled it off and submitted them separately to you. Those things are always helpful to know. So this is a case of clear cell carcinoma, and clear cell carcinoma at low power does have a complex architectural pattern. There's some stroma, but when you go down on high power, you can see that characteristic cleared out cytoplasm and then the hobnail shape of the cells. And clear cell carcinoma doesn't tend to have quite as much nuclear atypia as something like a serous carcinoma, although they are atypical. And the other thing that they like to have is the sort of hyalinized cores, which I'm seeing a little bit in here. You get that cotton candy sort of fluffy material in the cores, which can also be helpful. So this is a nice clear cell carcinoma, and keep in mind clear cell carcinoma doesn't have to have cleared cytoplasm like you can see over here. Sometimes they can be eosinophilic, but you usually will see at least focal clearing in the tumor, so that's helpful. The next tumor we'll talk about is a Brenner tumor. So this is a publicly available slide. It's quite lovely. You have several cystic spaces here. And the thing that's lovely about this, so we'll start with the Brenner tumor. Brenner tumors are usually firm. The differential diagnosis when you cut into one is that it'll look almost like a leiomyoma. They're so firm and so hard, or a fibroma. And then when you see the microscopic view, you see these transitional type nests. They're usually irregularly shaped, kind of diving through this hyalinized stroma. And sometimes you'll see mucinous cysts or metaplasia associated along with it. Oh my gosh, that one looks like a dog. That's lovely. Okay, so these are the thoughts that go through my head when I'm signing out. It's good to let you know that pathologists see dogs, see cats, see things in the clouds, just like everyone else. So this one actually has some cysts associated with it, which when I looked through here very quickly earlier, I thought they actually I think that's keratin, so that's a keratinized cyst, never mind. But sometimes you'll see mucinous metaplasia along with a Brenner tumor. Those things like to travel together. This is interesting that it has a keratinized cyst with it. Maybe this was part of a teratoma or something. Two lesions that ran into one another, but either way, lovely, nice, good prognosis for that patient. This is another case of Brenner tumor. So at low power, what am I seeing? I'm seeing some ovarian stroma over here on the left associated with, it looks like old or some sort of involuting physiologic cysts, and then something that looks like that Brenner tumor we just looked at first. So you see these nested transitional type cells diving into this fibrous stroma. But then over on the right, this is actually a borderline Brenner tumor. So you get those way more complicated transitional type epithelium kind of lining a cyst. These can be infiltrative and atypical enough to be called invasive or malignant, but not in this case. So that's a good example of a borderline Brenner tumor. Not terribly common, but when seen, are often seen with that more typical Brenner presentation like I showed you on this slide and the previous slide. And then to close up, we'll talk about seromucinous tumors of the ovary. I don't know why this slide isn't really loading. There we go. And so first, like I said, I usually like to get my orientation, try and figure out where I am. And on the left, I see stuff that looks more like borderline tumor. On the right, I see something that looks more like ovary. There's a corpora albicans. And if I zoom in, actually, it looks like there's a little bit of whatever this is here. So probably whoever grossed this saw some papillae, and that's why they stuck that section in as well. And then you can see here more of a traditional cyst component, which is often the case in these ovarian tumors. One thing leads into another. But what's interesting is you are getting a hint that you see some cilia, then you definitely see some mucinous lining as well. So that's where the seromucinous tumor gets its name. These are not terribly common when you do see them. Like I said in the PowerPoint presentation, they are commonly associated with endometriosis, which is another thing I was sort of hunting for. Endometriosis is sometimes seen in areas like this, but I don't see any good endometrial stroma, so I think that's just a cyst component. Always makes one feel good when you feel like your tumor read the textbook. But nonetheless, this is a serum mucinous borderline tumor. It has that nice hierarchical branching pattern, or you get the sense that it starts out big and goes intermediate to small. It does have some of those eosinophilic detached cells that serous borderline tumor we looked at back at the beginning saw there as well. And just the same, it has mucinous and serous cells lining the tumor. So this is a seromucinous borderline tumor. And that's the last tumor I have in this segment. So thank you so much.